Tricuspid stenosis is a valvular heart disease characterized by the narrowing of the tricuspid valve orifice, which creates a mechanical obstruction to blood flow from the right atrium into the right ventricle during diastole. While tricuspid stenosis is relatively rare compared to left-sided valvular lesions, it typically occurs in conjunction with mitral or aortic valve disease. Rheumatic heart disease, the most common cause globally, it almost never occurs as an isolated rheumatic lesion and is nearly always associated with mitral stenosis. Carcinoid syndrome often leads to fibrous plaque deposition on the endocardial surfaces, resulting in both tricuspid stenosis and tricuspid regurgitation. Congenital tricuspid atresia or congenital webs. Other causes: infective endocarditis with large vegetations, right atrial myxoma, systemic lupus erythematosus, that is Liebman-Sachs endocarditis, or iatrogenic causes such as pacemaker lead interference. The latter two are unlikely to cause significant tricuspid stenosis. Tricuspid regurgitation is more likely. The narrowing results in a pressure gradient between right atrium and right ventricle. Unlike the left side, even a small mean pressure gradient, like more than 5 mm of mercury, is considered clinically significant. That is because it is a low pressure system and the tricuspid valve has the largest cross-sectional area among the heart valves. Systemic venous congestion. Elevated RA pressure is transmitted backwards into the vena cava, leading to jugular venous distension, hepatic congestion and peripheral edema. Reduced cardiac output. Limited right ventricular filling leads to decreased stroke volume, particularly during exercise. Fatigue and dyspnea due to low cardiac output. Right-sided heart failure causes abdominal fullness or bloating due to ascites, right upper quadrant pain due to hepatic congestion, and lower extremity edema. Jugular venous pulse is characterized by a prominent flickering A wave due to forceful atrial contraction against a stenotic valve. Auscultation reveals a soft, high-pitched diastolic rumble heard best at the lower left sternal border. Unlike the murmur of mitral stenosis, the tricuspid stenosis murmur increases in intensity during inspiration, the Rivero-Cavallo sign. Echocardiography is the primary tool for diagnosis and severity grading. Key findings include thickened, distorted leaflets with restricted motion, that is doming in diastole. Mean pressure gradient, a mean gradient 5 mm of mercury or more at a normal heart rate is generally considered indicative of significant tricuspid stenosis. A tricuspid valve area of less than or equal to 1 square centimeter defines severe tricuspid stenosis. Pressure half time to estimate tricuspid valve area is less validated than for mitral stenosis. Treatment is typically indicated when patients become symptomatic or are undergoing surgery for other valvular lesions. Diuretics are the mainstay to reduce systemic venous congestion and alleviate symptoms of edema and ascites. Percutaneous balloon tricuspid commissurotomy may be considered in isolated tricuspid stenosis without significant tricuspid regurgitation, though its use is limited compared to mitral valvuloplasty. Surgical repair or replacement, usually performed during surgery for left-sided valves. Bioprosthetic valves are often preferred in the tricuspid position due to a lower risk of thrombosis compared to mechanical valves in the low-pressure right heart environment.